Hello everyone, I'm Fran.
Hi everybody, my name's Jen.
And we are Infection Prevention Control Nurses from Gloucestershire Hospital's NHS Foundation Trust.
We are here with our podcast. It's called IPC in Action, and thank you for listening.
Hello and welcome back to our August podcast. We're going to be talking about something you might not expect, and we're going to be talking about winter preparedness in August. We know it sounds crazy, but better early than late, we guess.
Yeah, we can't go on enough about winter preparedness, and just as a nice way to ruin everyone's summer as the rain starts, we're going to get going. So, winter preparedness is not just about responding to outbreaks. It's about creating a culture where we can recognise symptoms early, isolate quickly, test promptly, and protect each other before transmission occurs.
So the reason that we discuss this so early on is because we obviously want to be prepared, but we have so many, as everyone is aware, there's so much pressure on our hospitals, the amount of people coming through the doors, the bed pressures, people being sick, patients and staff, visitors, and just the pressure that is produced by norovirus, respiratory illnesses like influenza, COVID, RSV. But it's also impacting on patient safety and, as I said, bed availability and just the flow and also staff well-being. So we want to learn from lessons that we've had through previous winters and try and input some of these actions early on and make sure that there is awareness around what we need to do to keep everybody safe.
Absolutely. So we're wanting to really move from what has possibly previously been more of a reactive approach, and we're trying to have a much more proactive approach to this winter.
Yeah, definitely.
Last year, for example, I'm just jumping the gun a little bit here, but last year, for example, we rolled out the point of care testing that was testing for COVID and flu and RSV in peds much earlier, and it seemed to really have a really beneficial impact on having the understanding of if these patients are infected with any of these respiratory viruses, and we were therefore able to isolate them more promptly, and we did have less outbreaks as a result of it.
Yeah, definitely. I think we also want to make sure that all of our resources are available, easily accessible, they're understandable, and you know who to contact if you need help.
Absolutely, yeah.
So what kind of lessons did we learn from last winter? It was a busy winter.
It was. It started, we seemed to be experiencing a slightly slower influenza season last time than previous seasons. We also didn't seem to be as heavily affected as some of our neighbouring organisations, which we were incredibly grateful for, but it also made us quite nervous as to what was to come.
Don't know when it's coming,
I think some of that could have been to do with the early rollout of the point of care flu testing, which had a really positive impact, pun not intended, really beneficial impact. What we did experience last year when the outbreaks did occur was sometimes there was a bit of a delay in that isolation, and it was almost what we need to remember, one of our sort of key messages that we are going to say, I don't know how many times on this record and throughout winter, is if you are concerned enough to swab a patient, you need to carry out those other actions in addition. If you're concerned enough to swab, you need to isolate them. You need to enhance your own PPE to protect yourselves.
Definitely. We know that's hard. We do. We're not completely I can't think what the word is, not completely naive to it. And we know that there are limited side rooms, but it's just about taking the actions to do what we can to isolate them, contacting our site, but we'll get into all of that. It's also just, how we've seen how quickly outbreaks of, say, norovirus can spread throughout our ward. So we want to make sure that we're putting a stop to it as soon as we possibly can by implementing all the actions that we are going to cover. And it just creates such a disruption and can be for days, sometimes weeks. So we want to make sure that's not happening to make sure our patients are safe and keeping flow throughout the hospital.
Yeah, absolutely. It's also just considering that patient experience. People are already unwell. We don't want to be giving them anything in addition to what has brought them into hospital.
Definitely.
Equally, their sort of visitors, friends, relatives, they may end up coming in.
Yeah.
We also don't want it then spreading further into the community. So it's just, like Fran has said, maintaining that patient safety and patient experience wherever possible.
Yeah. So I'm sure everyone's seen our little motto for the winter season is don't watch and wait, test and isolate, which is very important. So yeah, we're going to go through the steps to cover regarding what we need to do this winter.
Yeah, absolutely. So just sort of considering some of our key sort of winter priorities, as Fran's already alluded to, that sort of prompt isolation. Early isolation really, really matters. We know that we don't have enough side rooms. When it does come to the need for isolating, if you can't make a side room, contact site, contact us. Site can always contact the on-call microbiologist if it's out of hours and you're concerned that you've got an outbreak situation on your hands. But please don't wait.
Yes. I think it's also good to mention that, so Jen's recently come out with a isolation matrix. So that's a really good one to look at in terms of priorities for isolating.
Yeah.
But obviously if you're confused at all, you need any help trying to prioritise if you've got different infections in your side rooms, please don't hesitate to contact us.
Yeah.
But identifying those people early that if you did need a side room that they possibly could come out is always a good way. Always a good place to start.
Yeah, absolutely. It's handy to have them in your back pocket.
Definitely.
Test and isolate.
So we're obviously wanting to watch out very closely for respiratory symptoms. So high temperature, coughs, sore throats, sneezing, and making sure that we're obviously isolating and then testing as promptly as possible.
Yeah.
So, and that'll be testing for flu, COVID and RSV.
Yeah, so obviously it can be really challenging to differentiate for instance, if somebody is coming in with respiratory conditions already, it's then quite challenging to ascertain if these are viral symptoms or if they're related to an ongoing medical condition.
Yeah, definitely.
Try to use your clinical judgment. Like Fran said, it's those red flags that we're looking for, that sort of temperature spike, coughs, colds, runny noses.
Yeah, that's the one.
All of those winter joys.
Yeah. Similarly with diarrhea and vomiting, if you're noticing that your patient has started having more loose stool, they're feeling nauseous, they're not necessarily vomiting, but then they might start projectile vomiting, for example. We want to be looking at, is there anything that could be causing the diarrhea and vomiting?
Are they on laxatives? Are they on a shed load of antibiotics?
Yeah, exactly.
Just considering those things. But if we've got unexplained diarrhea and vomiting, we need to be isolating, sending a stool sample and calling the IPC team or site who can get in contact with the on-duty microbiologist if it's out of hours.
Yeah, definitely. So respiratory virus management is another sort of priority message to go into. So as we said, flu, COVID, RSV. There are other respiratory viruses, rhinovirus.
There are others available.
There are others available on option to us all.
These are our three main ones that we tend to sort of see in sort of peaks and troughs throughout the sort of winter season. RSV typically affecting the paediatric population a little bit more, but we have had some RSV outbreaks within our older population as well.
With norovirus prevention as well, so it can be a very rapid transmission. We've seen it happen within hours, within days. It spreads across a whole ward area. So we're wanting to recognise that early, as Jen was mentioning earlier, and protecting our vulnerable patients to make sure it's not happening to them if possible.
We need to sound our hand hygiene klaxon.
We need to we'll sort one of those out for next time. So hand hygiene, the single most important intervention that we can all take. Ideally, you would be using soap and water, especially if patients have diarrhea and vomiting, because it's that physical action of scrubbing your hands that's going to help get rid of the virus off your hands. So we can all do that effectively. and just making sure that we're keeping up with that. Also to keep ourselves well, doing that before eating and drinking, etc., is really important.
Absolutely. So while we are on the delightful topic of norovirus, so like Fran's already alluded to, key signs, vomiting, diarrhea, that rapid spread amongst our patients and often, unfortunately, amongst our staff groups as well. It can also just look like nausea in some people.
Yeah.
So we need to use our site mnemonic. So the S is suspect, isolate, gloves, hand hygiene, and test.
The thing to consider as well when you've identified that patient is to contact the infection control team. In terms of testing and sampling, whilst we want to get those samples as quickly as possible, for norovirus testing to be requested is something that our team has to sort out. We have to assess the outbreak. So if you can give us a call as soon as possible, that would be amazing.
Just as also a reminder, it doesn't matter in the slightest if the stool sample collected is mixed with urine, is off the floor, is in a sheet, is in a pad. It doesn't matter in the slightest.
As long as it's not in the toilet.
Yeah, just don't get it out the toilet.
Yeah. So we want to be putting that into practice early on. We will assess that, and also considering, we should all be doing environmental cleaning anyway, but making sure that we're stepping that frequency up, making sure it's on a very regular basis.
Yeah, that high touch point cleaning is really, really important in norovirus outbreaks. And it's also not forgetting those pieces of equipment that we just carry around all the time, like the baton phones.
Yeah.
Give them a good wipe.
Or your own personal phone.
Exactly, your own personal phone, your stethoscope that's around your neck all the time and touching lots of people. Give it a good old clean. Keyboards.
Good old keyboards, yeah.
And all the shared equipment that the patients use.
Exactly. So commodes, we recommend that all commodes are cleaned with red wipes, no matter whether the person has a known infection or not, because that will hopefully kill all of those bacteria and viruses. We also like to input enhanced cleaning during outbreaks as well, as much as possible. So making sure that you're raising any issues on the My Cleaning app, if you spot anything, speaking to your domestic supervisors, but also including GMS as part of our team, making sure that everybody's well, everybody's coping effectively.
Absolutely. Outbreaks are rubbish.
Yeah.
So checking in with one another is really, really important, because it's a really sort of challenging period. People are having to sort of answer the phone so much more because relatives might not be able to visit because they don't want to become unwell themselves.
Exactly.
So it is a super challenging time. So looking out for each other is obviously really, really important, and making sure that you're escalating if you're struggling. If you're an inpatient ward area, reaching out to your matron for additional support and so on and so forth. And
we're always here to support you. It's a big old part of our job is the outbreaks. We're very used to it. So we will come and assess the area every single morning until we're getting to a point where we can consider reopening it. Obviously, hopefully providing advice along the way, identifying any issues or challenges, and communicating with staff as well is really important to us. So
absolutely. Right, we covered noro.
As much as we can cover it, yeah.
So then, moving on to our other winter delight, respiratory viruses. So from what we've seen, what we typically do is look to the Australian flu season. What it remains a little bit unclear is we always thought that we got our flu season from Australia. There's actually a chance it might be the other way around.
So we might be trend-setting.
We might be trend-setting, folks. So we'll have to wait and see what's coming this year. But so as Fran's already mentioned, the typical respiratory viruses that we see, influenza, COVID, RSV, loads of other respiratory viral infections. We might have some parainfluenzas. We might have some human metapneumoviruses. There's tons of them.
Yeah.
So the prompt testing, we will keep going on about that. It's just so important to understand what we're working with.
Yeah.
Bearing in mind, of course, with flu, you can have a flu A or a flu B. Typically, flu B comes later on in the season, but you do get the odd red herring coming through occasionally. It's the importance of identifying these cases early And that's one of the massive benefits of the rapid diagnosis using the point of care testing. Now, we don't have a date that that's going to go live as of yet, but that will be communicated with those admission areas that have the point of care testing machines closer to the time.
Absolutely. And it also helps in terms of, like we were saying, isolating, because whilst we want everybody to be isolated, we know that's not always possible. So if we can get a test sent off, we can get the result back, and it turns out it's not flu or COVID or RSV or any respiratory virus, then at least we know that we can keep the patient where they are, unless there's another risk we've identified. So that's all just part of our risk assessments, something that our team can help you with. Possible cohorting of patients with the same virus, for example. So that's something we can all go into if it happens.
And then just making sure that we're communicating all of this information with patients and with visitors, making sure that patients are aware of their own results. If they've got flu, they're probably going to know because they're probably not feeling very well. But it's still really important that they are informed of this. We do that, but it's obviously also super important for the clinical team to do that. So it's just encouraging symptom reporting from the patients, equally from their visitors. You know, making sure that we're supporting safe visiting. There are obviously instances where visitors need to come in and they may well be unwell. It's just making sure that we're being respectful and kind and professional when we're dealing with that. We can offer them a surgical mask.
Keeping them well informed is the priority. We are not stopping visiting.
No.
We just need to make sure they're informed of what's going on.
And making sure that we're doing it as safely as we can.
Exactly. So in terms of being safe, we're going to talk about PPE again. So we just want to get the basics right effectively. So during previous winters, we may have input universal masking. That's not something that's going to be put in immediately and it's going to carry on throughout the whole winter. We assess the situation as it goes on and we will send out any comms if we need to on that.
And that's only as an absolute necessity to keep everybody safe. And hopefully we won't need to do it at all, but we'll just have to wait and see.
In respect of respiratory viruses, we want to make sure that every staff member that is working clinically is tested for, is FFP3 fit tested. So we want to make sure that is documented somewhere. You know what mask you can use, and making sure that we know how to do a fit check as well to protect ourselves.
So when you're putting on that mask, it's just performing that quick fit check, making sure it has a good seal around your face, and taking a couple of puffy breaths in and out to see if you can identify any leaks. Because if there's any leaking out, then viruses are going to get in.
Exactly. And if you have failed on the FFP3 mask, then thinking about the powered hoods to use as well. That might be if you've got facial hair or your face is too small for any of the masks, etc. So keeping an eye on that.
And these are available in the equipment library on both sites.
Absolutely. Also making sure that we're selecting the appropriate PPE for what we are going in to see. So for a respiratory precaution, for example, in influenza and COVID, we want to make sure we are wearing the FFP3 respirators.
Whether that's suspected or confirmed.
Yes, exactly. So start as soon as you see somebody with those symptoms, want to protect ourselves early on and other patients. Making sure that we're using gloves and aprons for direct contact as well. Making sure that when you are leaving a patient's room, you are removing your gloves and aprons before you leave the room.
Exactly, inside of that side room. Or if you're in a sort of a cohort bay, inside of that cohort bay.
Disinfecting your hands, leaving the room, taking your mask off and disinfecting your hands again, obviously disposing of it in the right place. Because if you're still in the room and you've taken your mask off, you're going to put yourself at risk immediately inside that room.
So absolutely. And we are in the process of redesigning the isolation posters because they have quite a big sort of COVID pandemic hangover. So they're not right, is the long and short of it. So we are in the process of redesigning them. We have a task and finish group that's currently running. And if anybody is interested and would like to join, you're very welcome to. But just to mention that, because these new isolation posters will hopefully have a much more simple, easy to follow prompt to remind staff regarding the different level of precautions you need to take, whether it's airborne and droplet, enhanced contact precautions, contact precautions, and then that protective isolation if we have anybody who has a impaired immune system or they're neutropenic or something.
And any results we get through respiratory wise or otherwise, we'll always advise on the PPE that we should be wearing as well.
Yeah.
Because not all respiratory viruses need to have an FFP. You don't need to wear one for all respiratory viruses, but we need to make sure that you are wearing FFP3s in the right instances.
Yeah.
So we will always let you know what you need to do. Appropriate PPE selection for enteric precautions, so on norovirus. So again, making sure that we're using gloves and aprons for that contact. The virus can be on surfaces, but also considering if somebody is projectile vomiting, that can be in the air.
It can become aerosolized.
Exactly. So we want to be wearing surgical face masks for that one as well.
Testing. So we've already, I think, sort of covered point of care testing.
Yeah.
But that will be coming through. It just enables that faster diagnosis. We can then enables the more appropriate placement of our patients in regards to whether or not they require isolation. It also then supports that clinical decision making.
Yeah.
We as an IPC team will carry out contact tracing of COVID and flu.
Yeah.
Flu does typically require that risk assessment of any use of antivirals for those exposed patients. But all of this is, will be documented on said patient CPR records and so on.
And like Jen said, we'll let everybody know when it's being turned on, and we'll let everyone know when it's being turned off.
Yes.
So most importantly, but obviously that won't be for a while. So as we've alluded to earlier, visitors, the public, what messages can we give them as well as ourselves and our patients? So whilst we're not restricting visiting, we are saying to visitors, please do not come in.
If you are poorly yourself,
whether that be respiratory viruses or DMV.
Yeah, understanding, of course, that there are those individual circumstances that we as a sort of hospital organisation need to be sensitive to and support where possible.
Respiratory etiquette as well, making sure that if a visitor does need to come in, that they're using coughing into tissues, disposing of them correctly.
Offer them a mask.
As well.
And
also if they are ill themselves,
we're trying.
Sure they possibly told us if they have spent
all of that signage, information for public and for staff, indicating any outbreak areas and so on and so forth. Just considering that sort of public facing.
So moving on, staying well at work and looking after ourselves. So personal protection that we can discuss, so seasonal vaccinations. So whilst these aren't happening right at this second, keep an eye out for any comms to do with being invited for a flu jab. Hand hygiene, as we mentioned earlier, soap and water is the most effective method, but also using gel when you're coming in and out of wards, remembering your 5 moments of hand hygiene.
Yeah, soap and water definitely what you need for any sort of norovirus outbreaks.
Yeah.
Respiratory virus outbreaks, alcohol gel will suffice unless they are sort of visibly contaminated.
Yeah. Looking out for each other as well. Everyone's very tired in the winter. It's cold, dark, rainy.
I'm tired now.
Yeah. We're already settling in. Just looking out for each other is the best way we can protect each other.
Absolutely. We need to really sort of stay firm with regards to staff must not attend work if they're poorly.
Yes.
If you've got any symptoms of diarrhea and vomiting, if you have, and then following that exclusion period, you need to be sort of 48 hours symptom-free prior to coming back to work. Equally, if you're feeling unwell with any respiratory viruses, please don't come into work. Please. We've got lots of vulnerable patients.
Yeah.
So it's just the safest place for you, if you're poorly, is at home.
Yeah, rest and relax and get yourselves better so you can come back to work. So the things that we're doing as infection control team this winter to kind of put everything out there, making sure the message is loud and clear. So as Jen said, refreshed winter posters, isolation signage, testing reminders, FP3 reminders, visitor information.
Yeah.
We're going to try and do more sort of waiting room messaging. We've got some big roll-up banners that we're redesigning as well for visitor information, screensavers. We've got we're going to have an internet sort of platform, a landing page that's easily accessible, as we mentioned with the...
Essentially, you won't be able to move without seeing some communication from us come this winter.
Exactly. So we'll have our respiratory and norovirus toolkits on our landing page. We're going to be doing some staff vlogs, so you'll be able to see our lovely faces very soon. Obviously, we'll keep you updated with regular podcasts during the winter, newsletters, keeping in contact with GMS as well.
Absolutely, yeah. And it's just sort of reflecting back a little bit on last winter. We had a couple of outbreaks that were really quite sustained, and they were actually just at the end of what would be the typical influenza season. And it's just considering that difference between a single case and an outbreak can be measured in hours, not days.
Exactly.
This winter, we just want to really focus on recognising symptoms early, testing promptly, isolating quickly, and using the right PPE.
Yeah.
We need staff to stay at home if they're unwell, and just remembering that these small actions can, when taken early, can protect our patients, our staff, and the capacity and flow in our hospitals.
Yeah. So that's it from us. We hope it wasn't too much of an overload of information. And as we said, we know we're very early with the winter preparedness, but we just want to be prepared. So if you need to contact us at all, any questions, as per usual, you can contact us on our extension 6122 for Gloucester, 3129 for Cheltenham, or our group email address. And we will see you next month.
Thanks, everyone.
Thank you. Bye.